Good afternoon. My name is Chris Buchmeyer. I'm the Chief of Operations here at Warwick Ambulance, and for this session, we're going to be talking about capnography. For those of you who don't know me, I've been a paramedic for about 30 years. The last 19 of them, I've been working here at Warwick Ambulance. If you have any questions during the presentation, please type them in the chat box, and I will answer them on the fly. The ancient Greeks believed that people had fires burning inside them that produced smoke. They called this smoke capnos, which is where we get the term capnography. They weren't entirely wrong. Today, we call we call fire metabolism, and the byproduct of metabolism is CO2, and that's our smoke. Getting right into it, we've all had this patient, a 61-year-old male who's short of breath and exhausted. He's been smoking cigarettes for the past 45 years. He's had 3 MIs and a history of hypertension. He doesn't take his medications every day because they're too expensive. You look at his physical exam, he has pitting pedal edema, wheezing and crackles in his lungs, a heart rate of 92, a blood pressure of 160 over 100, pulse ox of 73% on room air, and a respiratory rate of 18. Without more information, what's your differential diagnosis of this patient? So what is capnography? It's an objective measurement of your patient's ventilatory status, and it shows you a graphic representation of that status in the form of a waveform. It also gives you a numeric value of expired carbon dioxide. End tidal CO2 is the peak amount of expired carbon dioxide, and that number is the number that you see on the monitor, and it's a breath-by-breath measurement of the patient's expired CO2. Like any other living thing, humans use fuel to produce energy that is then used to perform certain tasks. The byproduct of that energy cycle is carbon dioxide, among other things. The carbon dioxide produced in each cell is transported to the circulatory system and then to the lungs for exhalation. Think of it as your body taking out the trash. A little history about capnography. It was first used in the OR in the 1970s and became the standard of care there in 1991. Like many other things, it didn't make it out of the OR until the technology became small enough to make a device portable. There are 2 types of capnography, volume capnography and time capnography. In EMS, we use time capnography, and in most of the hospital disciplines, they also use time capnography. For the remainder of the presentation, we're going to focus on time capnography, and I'll just use the word capnography instead of differentiating the two. Capnography is now used throughout the hospital, albeit more sporadically than it's used in EMS. It can be used for both intubated and non-intubated patients. In the ER, it's used a lot for conscious sedation. In the recovery room, it's used to monitor patients who were under general anesthesia and are regaining their consciousness. And in the ICU, it's used a lot for intubated patients. There are 3 types of time capnography detection. Colorimetric in the bottom left-hand corner of the slide is only good for telling if there is CO2 present in the airway circuit. It uses a type of litmus paper and is subject to a number of problems, such as it can't be subjected to moisture, and it's only useful for a few minutes before the moisture in the expired air makes it unusable. Capnometry, in the top right-hand corner of the slide, will give you a number and a respiratory rate, but no waveform. It has its place in emergency settings specifically to verify tube placement. Capnography is the one that most EMS providers are familiar with in the top left-hand corner of the screen. It provides a waveform and a CO2 measurement. There are 3 types of capnography: mainstream, side stream, and microstream. Mainstream capnography has a sensor in the breathing circuit. Side stream and microstream have the sensor located in a separate device, and the sample is piped to that device. Each type has its benefits. Mainstream has no delay, as opposed to the others, which have a 1 to 2 second delay. The downside of mainstream is that the fragile sensor is subject to damage and is located right in the airway circuit. It also can only be used on intubated patients. Side stream and microstream can be used on both intubated and non-intubated patients. The difference between side stream and microstream is the sample size. Side stream needs 1 to 300 milliliters of expired air, while microstream needs only 50 microliters of expired air. Most EMS monitors that I'm familiar with use microstream technology. Capnography works by shining a light on the sample. That light is at a specific waveform that's easily absorbed by carbon dioxide. The light that makes it through the chamber is measured to determine the amount of CO2 present. So what about the pulse ox? Well, there's a couple of differences. Capnography measures ventilation, or the movement of gases, and pulse oximetry measures oxygenation, specifically how much oxygen is in the bloodstream. Both capnography and pulsimetry are important to EMS providers and play a crucial role in patient care. We measure ventilation for several purposes. ET tube placement is one of them. The waveform of a capnogram can unequivocally confirm ET tube placement initially and throughout patient contact. End tidal CO2 can also tell us how well CPR is being performed and when the rescuer gets tired. Many times, ROSC will produce a spike in end tidal CO2, letting us know that we have ROSC, long before we'll feel pulses or before we're able to get a blood pressure. We'll talk about the role of capnography in the head injured patient a little bit later in the presentation. You'll be able to see how severe a patient's bronchospasm is based on the waveform and how effective or not your treatment is, all based on the capnography waveform. A real quick side note about blood gases. First of all, a normal end tidal CO2 should be between 35 and 45. I have to say that I've seen some patients who live in the mid to upper 20s and low 30s, and I see that, if I see a patient more than once, I know to kind of remember that kind of thing. A normal PA CO2 from an ABG is between 38 and 42 millimeters of mercury, so it's a little bit lower. While this won't help us a lot in the pre-hospital arena, reporting an end tidal CO2 is important when comparing it to an ABG, and that the difference between the two shouldn't be more than 5 millimeters of mercury. Anything more than that needs to be investigated by the hospital staff. Reading an end tidal CO2 waveform is similar to reading an EKG. Having a specific algorithm is very helpful. First thing to do is look at the frequency. How fast is the patient breathing? Next, the rhythm. Can you predict when the next breath is coming? Different pathologies cause people to breathe irregularly, and that needs to be investigated. Next, we'll look at the height. How tall is the waveform? This equates to the level of CO2 that is being exhaled. Next, the baseline. How's the baseline staying? Is it staying at 0? Is it slowly creeping up? Is it slowly creeping down if it's above 0? And what does the shape look like? This is probably the most important one. Is it square? Is it slanted on one side? Does it have rectangles in it and whatnot? Just like reading an EKG, all of these are important to the overall interpretation of the waveform. On another note, the waveform is divided into 5 segments, and we're going to look at each one of those individually. The respiratory baseline is known as phase 1. It represents the time that your lung is expanded and full of gas or air, and during this time, gas exchange is taking place. The capnography waveform is a bit counterintuitive in that it shows exhalation before inhalation. Phase 2 is the expiratory upstroke, and this is the first part of exhalation when the majority of air, including CO2, is removed from the body. Phase 3 is called the alveolar plateau. The air that was in the alveoli is now being expelled. You'll notice that there's continued increase in the amount of expired CO2, and the amount of CO2 at the end of phase 3 is what we know as the end tidal CO2. The last phase is known as the inspiratory downstroke. Since there's relatively low amount of CO2 in expired air, the waveform drops to the baseline or 0. Here's a non-pathological capnography waveform. You can see that phase 1 is at 0. Phase 2 goes almost straight up. There's a small increase during phase 3 before it drops straight down in phase 4 before it repeats itself. It's rhythmic, which means you can predict when the next one's coming. The height is between 35 and 45, well, right at 45. The baseline doesn't change from breath to breath, and its shape looks like a square. What would you change if you started intentionally breathing at 30 breaths per minute? The frequency would definitely increase. The duration would decrease, meaning that phase 3 would be shorter. The height would decrease, but why? As the respiratory rate increases, you blow off CO2, the amount of CO2 would decrease on the capnogram. What about the shape? You're right, it would stay about the same, hopefully still square. So what are we going to use capnography for? We can measure the patient's ventilatory status on a breath-to-breath basis. Capnography provides real-time information about the ABCs, and we can use it to objectively document our treatment. Capnography plays a significant role in the intubated patient and specifically those in cardiac arrest. After intubation, a continuous waveform allows verification of ET tube placement. It also allows us to continuously monitor tube placement during movement and transport. ALS providers who've taken ACLS know that you're supposed to monitor or recheck the tube placement after each movement of the patient. So if you move them from the floor to the litter or the litter to the hospital litter or wherever, you should recheck the tube to make sure that it hasn't become dislodged. Capnography makes that super simple. Along with confirming tube placement, in the old days, there were several ways that we used to verify tube placement. I mean, this was a long time ago, back when we were still doing charts on stone tablets. We would listen to breath sounds and listen to the belly for sounds there. The problem with that is it's difficult to hear those sounds in a noisy environment. And I don't know about you, but I've never been to a quiet cardiac arrest. Chest rise can still occur with esophageal intubation. You blow up the stomach enough and it's going to push on the chest, and you're going to still see movement of the chest. Fogging of the tube relied on the temperature difference between the stomach and the outside air, and it doesn't really have anything to do with carbon dioxide or any other physiological feature. So you squeeze the bag a couple of times before the patient's intubated. Some of it goes into the belly and then it comes out, and now you have fogging in the tube when it's in the stomach. The turkey baster in the top right hand corner of the screen works by assuming that the esophagus will collapse under pressure of the bulb trying to expand. The theory is that if the ET tube is in the trachea, air will still move through there and the bulb will expand, and you'll be able to say that you're definitively in the trachea. The problem with that is it doesn't always work, because there's still air sometimes in the esophagus, and the bulb would always blow up. I can't remember a time when it didn't blow up. We've already talked about the problems associated with the EasyCap or the colorimetric end tidal CO2 detection. The new way, or should I say the current way, is to use capnography. Capnography provides an objective confirmation and ongoing confirmation of placement, and it can also make documentation of a tube very simple. After the patient is intubated, all you're looking for is a squared waveform on the capnogram. Patients in cardiac arrest typically have a CO2 between 10 and 20 just due to the poor cardiac output of CPR. The Falk study looked at 216 patients. 108 of them were intubated and confirmed using the old methods. Of those 108, 27, or about 25%, had unrecognized misplaced ET tubes, whether they were in the hypopharynx or in the esophagus. The other 108 were intubated and confirmed with capnography, and they had absolutely zero unrecognized misplaced ET tubes. There are a few caveats to tube confirmation in cardiac arrest. If the patient codes shortly after drinking a soda, or after you intubate them after having some mouth to mask ventilations, there could be some residual CO2 from either the soda or the patient or the person who was doing mouth to mask ventilations expiring some CO2 into the patient. The good thing is that CO2 will be washed out after approximately 6 breaths, and if you continue to have a nice squared waveform, then you're safe to say that you're in the trachea and not in the esophagus. I want to warn you not to be fooled by the picture of the nice squared waveform for a esophageal intubation. They don't look that nice. Nothing like what you're going to see if you have intubated the trachea. After you have somebody intubated and you're having the nice squared waveforms, and all of a sudden you see this complete loss of a waveform, it could mean a couple of things. The tube could be dislodged and in the hypopharynx. It could be kinked somehow, or it could be obstructed. And each one of those needs to be investigated and resolved as necessary. If after you have somebody intubated, you notice instead of a complete loss of the waveform, a slowly decreasing end tidal CO2 with an abnormal looking waveform, there's a couple of other things that you should look for. First of all is a leak in the cuff on the ET tube that could cause some air movement and air going past the tube and not going into the circuit so that the CO2 is not detected. You could have had a misplaced tube that's in the hypopharynx, or you could have a partial obstruction. The nice thing about it's not a nice thing about the partial obstruction is you're not going to have a complete loss of waveform. Like in the last slide, it went almost straight to zero. You'll see on this slide that it looks kind of like a point, almost kind of like a Hershey kiss. And that's indicative of usually a partial obstruction or a problem with a valve on a ventilator, or the BVM is having an issue or something along those lines. So in addition to ongoing confirmation of tube placement, you can also check for the effectiveness of CPR, specifically if you're not using a device like a Lucas or an Autopulse or something along those lines. If you have a continuously square waveform and a slow drop in CO2, it probably means that the person doing CPR is getting tired and it's time for someone new to do CPR. In the absence of capnography, that's why we're changing rescuers every 2 minutes to prevent rescuer fatigue. Capnography will also tell us if we have ROSC, and it'll do it pretty quickly. We'll talk about that in the next slide. We are all aware that properly done chest compressions are the hallmark of a good resuscitation. Quality chest compressions allow oxygen to get to the patient's vital organs and allow metabolic wastes to be returned to the lungs for exhalation. Even with the best chest compressions, CPR is not nearly as effective as the patient's own heart doing the work. When rescuers doing CPR start to get tired, their efficiency decreases. So the 10% of normal blood supply during CPR is going to decrease. When that decreases, carbon dioxide being made in the cells is not getting back to the lungs to be exhaled. Changing to a rested rescuer should bring your CO2 levels back up to the normal CPR levels. Capnography can also be used to predict the outcome of a cardiac arrest. Cells in our body die at different rates. We're all familiar with the fact that the heart and lungs can survive for between 4 and 6 minutes without oxygen. Other body parts can survive for longer periods of time, and each body system has a different length of time it can survive without oxygen. When averaged out, most of our body systems can survive for about 20 minutes without oxygen. An end tidal CO2 of less than 10 millimeters of mercury for 20 minutes has been proven to predict a poor outcome in cardiac arrest patients. The reason why it's a good predictor of poor outcome is that once the cells in the body start to die, they stop making carbon dioxide as a byproduct of cellular metabolism. And when the cells aren't making carbon dioxide, there's no CO2 to be returned to the lungs for exhalation. And as I mentioned before, capnography can also be a predictor of rescuer fatigue. What about the patient who is intubated but still has a pulse, specifically those with a head injury? A patient with a head injury and some type of intracranial hematoma is at risk of worsening hematoma if their end tidal CO2 is too high. A high end tidal CO2 is associated with dilation of cerebral arteries, which could worsen the intracranial hematoma due to increased blood flow. Hyperventilation, on the other hand, is associated with at least a doubling of the death rate of patients with a head injury in the intubated patient. A low end-tidal CO2 will cause constriction of cerebral arteries, preventing adequate oxygenation of the brain, causing hypoxia, which could cause a secondary injury. This means that capnography is crucial to the survival of the head injured patient. Keeping the patient's end-tidal CO2 at a target of 40 millimeters of mercury has been associated with positive outcomes because doing so will maintain adequate cerebral blood flow and minimize secondary injury. Few clinicians, regardless of their specialty or level of training, can adequately ventilate an intubated patient. Too frequently, it's too fast. Even the most experienced clinician can get caught up in the action of a critical patient and not pay close enough attention to the respiratory rate. There are, however, several things that can be done to prevent unintentional hyperventilation. Here at Warwick EMS, we use a ventilation timer. There's a picture of it on the slide. It's a small addition to our BVMs that has a simple LED that blinks once every 10 seconds. We just squeeze the bag each time the light blinks. That small device, coupled with end-tidal CO2 monitoring, prevents unintentional hyperventilation. If your service doesn't have it, I would highly recommend you get some of these, or at least suggest it to whoever is in charge of your organization. Another non-cardiac arrest use of capnography in an intubated patient is the monitoring of sedation. If you see the little Curie cleft there on each end-tidal CO2 waveform, and that's indicative of the patient is coming out of their sedation. It's the patient's trying to take a breath, but they're still sedated enough that they can't take a full breath. If the patient's going to remain sedated, this is the time where you need to add additional sedation, or if your goal is to remove the sedation and extubate the patient, this is a good indicator that that time is coming soon. Next, we'll move on to the non-intubated patient. There are countless uses for capnography in the non-intubated patient, and we won't be able to get into all of them today, but we'll touch on some of the big ones that we see in EMS on a regular basis. I realize that I'm going through this pretty quickly. If you have any questions, like I said, put them in the chat box and I'll be able to answer them on the fly here. Okay, so we spoke about airway and circulation, the A's and the C's of the ABCs, and how they play a role in the management of the intubated patient. Let's talk a little bit about the non-intubated patient. We'll discuss mostly the B's of the ABCs here. Capnography can help us guide our treatment in patients who are hypo or hyperventilating, COPDs, diabetics, people who are septic, and a number of other patient populations. Capnography plays a big role in our diagnosis of bronchospasm. As we know, bronchospasm is the uneven filling of alveoli during inspiration and the uneven emptying of alveoli during exhalation. This causes a characteristic shark fin waveform on the capnogram. Consider a movie theater with 3 doors at the back. When the movie's over, everybody gets up and walks out the 3 doors and the exit. Everybody leaves at the exact same time. With the moviegoers, they're able to leave without any type of backlog. Guess what would happen if 2 of those doors were closed and everybody had to file out a single door? It would take 3 times as long for the theater to empty, and the same thing happens with bronchospasm. It takes a lot longer for the air that's in the lungs to get out, and that's how we get the bronchospasm. The shark fin waveform. When there's an extended exhalation time, phase 2 and 3 kind of run together, and it's called a loss of alveolar plateau, and that's again where we get the characteristic shark fin waveform that you see at the bottom of the screen. So we talked about the loss of the alveolar plateau, and as you look at the alveolar plateau on this slide, it's the part between C and D. When you lose that, C kind of goes away and B kind of melts right into D on the slide. And the amount of loss is directly proportional to the severity of the bronchospasm, as we'll see on the next slide. Remember our patient from the beginning, the 61-year-old male who was short of breath and exhausted with several MIs, hypertension, and a significant smoking history? He said his medications were too expensive to take every day, and he was severely hypoxic with pitting pedal edema. We also heard rails and crackles in his lungs. Without capnography, one must wonder if the patient is in congestive heart failure or if he's having an exacerbation of his COPD. We know that bronchospasm is triggered by allergies, pollutants, exercise, stress, and in this case, lung disease. The small airways in the lungs become irritated and inflamed due to these triggers. This inflammation results in wheezing, coughing, and shorter breath. Capnography can answer the question of whether it's COPD or CHF for us. We can put the capnogram on the patient, and if he has a shark fin waveform, as you can see here, we can treat the patient for his COPD with bronchodilators. You'll notice that after the first DuoNeb treatment, the patient's alveolar plateau returns slightly, and after the second DuoNeb treatment, the patient's capnogram returns to normal. If you're using the LifePak 12 or LifePak 15, you can hit the print button twice in between the DuoNeb treatments to document the patient's improvement. And I say LifePak 15 or 12 only because that's the monitor that I'm most familiar with and haven't used many of the other monitors recently. Let's move on to the next example. Consider this patient. He's still short of breath and exhausted, still a smoker, still had MIs and hypertension, still doesn't take his medications. Physical exam is virtually identical to the previous patient's. The only difference is the patient's capnogram. You'll notice that his has a squared waveform, well, mostly square, and the patient's wheezes are caused by cardiac asthma. And it's called that because it's virtually undistinguishable from bronchospasm or pulmonary asthma, but the pathology is completely different. An accurate diagnosis is imperative because treatment for the two conditions differ, and incorrect treatment can exacerbate a patient who's suffering from cardiac asthma as opposed to pulmonary asthma. Cardiac asthma is a clinical syndrome induced by acute passive congestion and edema in the lungs. It occurs when the left side of the heart suffers from a sudden disproportion between workload and work capacity. This patient, who has had 3 MIs, has a weakened heart or work capacity, and because he hasn't been taking his medications, such as an ACE inhibitor or a diuretic, fluid builds around the lungs, causing decreased area for air movement. As we saw before, the treatment for bronchospasm is bronchodilators and steroids. The treatment for this patient would be diuretics, nitrates, and CPAP, depending on the severity. Moving on, hyperventilation can be caused by a number of factors, including sedation, narcotic overdose, CVAs, or seizures, etc. In this capnogram, the patient is suffering from a narcotic overdose. You can see an elevated end-tidal CO2. It's about 75 right now, and a slow respiratory rate. After treatment with Narcan, you can see that the patient's CO2 has dropped and his respiratory rate has elevated to a much more life-sustaining level. It's important to point out, now since I have this capnogram up here, that the capnogram that you see printed out is going to be considerably different than the capnogram that you see on your screen, insofar as the one that you see on the screen of the monitor is condensed so that you can see more waveforms in a shorter space. So the one that you see when you print it out is going to be much more accurate, and if you are diagnosing bronchospasm or hypoventilation, you're going to want to print out a strip so that you have a decent view so you can see what you're looking at. Capnography is also useful in patients who are hyperventilating. You'll notice in the bottom capnogram with the orange and green waveforms, the frequency is decreased, but the rhythm is still predictable. The height increased, but the baseline and the shape haven't changed. The patient's end-tidal CO2 has increased because the patient isn't breathing fast enough to remove all of the carbon dioxide that's being made by metabolism. The same holds true for the top capnogram with the orange and the pink. The patient is breathing faster than her body can make the CO2, causing her end-tidal CO2 to drop. There are some low perfusion states that also cause a change in end-tidal CO2, including atrial fibrillation and bundle branch blocks. Each of these conditions cause a drop in end-tidal CO2 levels due to an increase in cardiac output. Hypovolemia causes a decrease in end-tidal CO2 because while the body is still producing the same amount of carbon dioxide, that carbon dioxide can't get back to the lungs to be exhaled. The last reason we're going to talk about that end-tidal CO2 may be low in low perfusion states is pulmonary embolism. Because pulmonary embolisms obstruct pulmonary blood flow and not the air movement, the capnography waveform is going to look normal. It's going to have a normal shape, but combined with a low SpO2, a low end-tidal CO2, a normal waveform with clear lung sounds, those are strong predictors that the patient may have a pulmonary embolism. Capnography offers an indirect method to detect diabetic ketoacidosis, and diabetic ketoacidosis is a form of metabolic acidosis. When the body is acidotic, we instinctively increase our respiratory rate to compensate, causing our end-tidal CO2 to drop. A patient in DKA will usually have a high blood sugar and a low end-tidal CO2 due to the increased respiratory rate. In a study done in 2016, patients who were hyperglycemic with an end-tidal CO2 of less than 25 was 90% specific for diabetic ketoacidosis. Septic shock, which will be discussed in a later session, causes organ hypoperfusion, which in turn causes serum lactate levels to rise, and lactic acidosis follows soon after. We've already learned that the body's response to acidosis is to increase the respiratory rate to attenuate the metabolic acidosis, causing end-tidal CO2 levels to fall. And there is an inverse relationship between serum lactate levels and end-tidal CO2. As lactate rises, carbon dioxide levels fall. End-tidal CO2 levels have been shown to be an accurate predictor of mortality in patients with severe septic shock and sepsis. Another study found that end-tidal CO2 levels less than 25 millimeters of mercury are strongly associated with serum lactate levels of 4. You should tune in to Alex Arder's session at 1500 to learn more about sepsis. Please keep in mind that this was only a brief overview of end-tidal CO2 and capnography. There are many online resources and peer-reviewed journals that discuss capnography in much greater detail than I had time to talk about here. If you have any questions, my email address is on the screen, or you can type them in the comments. I'll be around for a couple more minutes to answer any questions, and I hope that you're enjoying the Con Ed Bliss, and hope you have a great day. Thanks.